Morning. Still, good morning. It is, I'm sorry, it is March 3rd.
April 3rd.
April 3rd, March.
Wow. April 3rd. Reverse.
And quickly, we're gonna do a walkthrough of S-154, which is a bill we just received from Senate. So whenever you're ready.
Jen Carby from the Office of Legislative Counsel. I'll put the language up on the screen. This is an act relating to health insurance coverage for biomarker testing. And this asks for some studies and a report. So it starts out with definitions, and I will take a step back and say the bill as introduced in the Senate would have required health insurance coverage for biomarker testing. This is taking a step back from that and looking at the cost implications first. So it's
Strike all, perhaps?
it's a strike, yes, but it uses a lot of the same language. All of the definitions are the same, for example. As used in the section, biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a specific therapeutic intervention, including known gene-drug interactions for medications being considered for use or already being administered. And biomarkers include gene mutations, characteristics of genes, and protein expression. Biomarker testing means analyzing a patient's tissue, blood, or other biospecimen for the presence of a biomarker. And the testing includes single analyte tests, multiplex panel tests, protein expression analysis, and whole exome, whole genome, and whole transcriptome sequencing.
Oh, are you right?
Yeah, and I'm going to let other people tell you what all those mean. Consensus statements, I won't go into the details of that right now, but these are consensus statements by kind of bodies of experts. Nationally recognized clinical practice guidelines, again, has a definition that we don't need to go through, I think, in detail at the moment. You can get it from the name, but it's important to the language of the bill. This directs the Department of Financial Regulation and the Agency of Human Services to analyze the costs associated with requiring health insurance coverage and Medicaid coverage, respectively, for biomarker testing for the purposes of diagnosis, treatment, appropriate management, and ongoing monitoring of a patient's disease or condition when the test is supported by medical and scientific evidence, including labeled indications for a test approved or cleared by the FDA, indicated tests for an FDA-approved drug, warnings and precautions on FDA-approved drug labels, CMS national coverage determinations or Medicare administrative contractor local coverage determinations, or nationally recognized clinical practice guidelines and consensus statements. So that's why those definitions are in there. On or before January 15th, 2027, DFR would report to this committee and the Senate Committee's jurisdiction on the estimated amount that health insurance premiums would increase if Vermont were to enact legislation requiring health insurance coverage of biomarker testing, including the amounts of the state's financial obligations for defrayal, the state defrayal concept of premium increases for qualified health benefit plans as required under federal law, and for premium increases in the state employees' health benefit plan. So figure out what the likely premium increases would be if biomarker testing was covered. And you'll hear, I think, from other folks about why they think biomarker testing should be covered and what value it may bring. Also, by January 15th, 2027, the Agency of Human Services would report to this committee and Senate Health and Welfare on the approvals that would be needed from CMS in order for Vermont Medicaid to cover biomarker testing and the costs to the Medicaid program if Vermont were to enact legislation requiring that coverage. And it would take effect on passage. So there was a lot of interest in pursuing coverage downstairs, a lot of interest in pursuing coverage for biomarker testing. I think they heard a lot of compelling witness testimony, but there were also concerns about what the financial implications would be for the state. And so wanted to have some analysis done first.
Is this sort of we've done this multiple times around changing our benchmark
We
plan,
wouldn't be looking at changing our benchmark plan. This would be looking at
how much it would cost.
what the state defrayal obligation would be, because the state has to pick up any premium increase attributable to a new insurance mandate for qualified health plans. Also, what the cost would be to the state employees' health plan, and then what the Medicaid cost would be, and whether we would get CMS approval.
Okay.
So yes, and I think some of the testimony that they heard downstairs looks at potentially avoided costs down the road from having testing and appropriate diagnosis earlier. But there are financial trade-offs in the shorter and longer term for that too.
I honestly have no idea. I know that the Senate oftentimes will strip out an appropriation until the budget comes to them. And was there ever an appropriation in this bill?
There was not an appropriation in this bill because it was just doing right. And I would have to look. I believe there is a fiscal note on this. There were a few different things that were being asked for, and I don't recall as far as actuarial analyses which ones were and were not included. Let's see, I'm looking at Nolan's fiscal note. So DFR did not specifically request an appropriation, but it may be necessary. I think AHS had testified, although you can hear from them, but that they could do the work under their current actuarial plan design contract. But DFR may be appropriate.
Well, first time I've seen this. Okay, I haven't read it all.
Everybody.
Okay, so I'm just thinking, so we're talking about dealing with health insurance, Medicaid and Medicare.
Not Medicare, just health
Not
insurance.
Medicare would not be
We
part of
can't,
it.
no, because we can't tell Medicare what to cover.
Okay, so this is a kind of like a study to get the cost of what this
Exactly,
would
it's
cost.
exactly what it is. Yes, there was
And they
interest.
report to,
They report to the legislature
okay,
in January,
and then we determine
and then you decide if you
whether we
want
should
to,
pursue that.
right, if you want to
Okay,
pursue, if you want to
Okay.
pursue legislation requiring coverage.
okay.
Can I ask a question? Sure. Let's be cognizant
And I
that
have to.
Yeah, you may need to, and this could be for another time. I just want to understand a little more about state defrayal and what that means. When it says mandated pay, that we pay for costs beyond our standard benefits, and I just don't really understand that, and that might be for
Yes,
another.
I'm happy to come in and talk a bit
Yeah.
more about state defrayal. One thing I cannot necessarily answer in any given situation is, would the state have to pay for this under state defrayal? Some of that would require further analysis, but we can
But
talk
just over the
about.
concept.
we'll get into
Defrayal,
the
yes.
concepts behind it. Okay,
I will be
great.
back.
Shortest walkthrough ever.
Yeah.
Just introduction to it.
Oh, I left goodness, thank you. That is not mine.
Okay, when Jen gets out, we are gonna move on to Jessa is testifying on 197. And I am turning this over to Daisy for all of about 2 minutes. I will be right back. Okay? Oh, Daisy.
You can do it for 2 minutes.
Morning.
Switching gears,
Switching
right?
gears, yes, and I'll give you a minute, so I have to take a minute. Yes, 'cause I also have to take a minute and get my slides up, so, you should have my slides already on your website. And I will also show them.
We can use it, right? We can move around. Look at that.
Oh, no.
You have space to stuff. Yeah, okay. So yes, 197, primary care. My goal for a little time this morning, and thank you very much for giving me time on I know you've heard a lot this week. It's been a long week. What I am hoping to do is pull together a little bit of make the link between some of the testimony you've heard from the amazing primary care practitioners you heard from this week with sort of what's in 197. Why does 197 help move the ball and help make things better for primary care? Why is my organization excited about it, and the members we've spoken to who are primary care practitioners excited about it? So that's what I hope to accomplish. Stop me at any time. And again, thank you for your time on a Friday. So the goals of 197, I would argue, are to increase sustainability of primary care and access to primary care. And there are three main levers the bill uses: a primary care investment target, primary care payment reform, and strengthening the primary care workforce. I am excited that the bill both moves the needle on investing more in primary care and paying differently, but we're using Vermont's existing infrastructure. And I think that's why the bill maybe flies a little bit under the radar, or you may have people saying it's not doing enough, because it's not something new and big and shiny, but it is using trusted, proven tools we have to, I think, actually make really significant progress to strengthen primary care in our state. So I'll first talk about payment reform. And the first step, I think of the bill as kind of doing things in steps. What the bill, I think, first does in paying differently for primary care is strengthening what we have. So you heard from John Soroyan, you heard from the Blueprint about these kind of what I call an add-on payment for practices that meet this patient-centered medical home. You heard about the NCQA designation. When they do that, they get this extra monthly payment for each of their patients from the different payers. What the bill does in Section 2, it expands the definition of insurers that are contributing to that. It requires all insurers to contribute equally to Medicaid, which is currently $465 per person per month. And it also strengthens the role of the Blueprint executive director to adjust those contributions annually. So what does that do? Why is that in the bill? What would it actually do? There was a report, the Act 51 report from 2023, that recommended bringing all payers in to support the Blueprint. There are the payers, especially the larger employers, the third-party administrator plans, the ERISA plans, who do not contribute anything to the Blueprint. I believe that this is a mechanism, the way we're defining insurers to include those plans, that we could expand which payers are contributing. There is a interesting analysis out of Massachusetts, which is looking at a similar primary care expansion program of how their program interacts with ERISA, the federal law that governs those plans, and saying basically an assessment on ERISA plans is allowed. You can't tell them what to do about their benefits, but they can contribute to, and they can be assessed payments. And so if the determination is that this is the assessment we need of all payers to support this program, we're not telling them what they have to do for their plan design, their benefit design. We're simply saying every insurer is assessed the same amount in our state, that we could likely do that. This means that we could increase support for primary care without increasing how much we're asking of our existing payers. So we know Blue Cross Blue Shield doesn't have, and MVP don't have money lying around. They can't necessarily we can't necessarily ask them at this moment in time to do much more to support primary care, but could we get everyone in who's currently not contributing? So that alone could significantly increase the support primary care practices are getting. We also know that of those existing commercial payers that are contributing, and hopefully more of them, that their contributions are lower than Medicaid and is not keeping up with the costs for a practice to meet this patient-centered medical home requirements. That takes a lot of, you've heard the staff that requires, the time that requires to collect those measures. So our organization believes that should be more adequately supported, and this would be a way to do it. So that's step one, sort of expanding or growing our existing patient-centered medical home, sort of what I think of as an add-on payment. Remember, they're all still billing fee-for-service for all of the other services they're providing. Step two is, can we actually reimagine that scope? Can we go from an add-on payment on top of fee-for-service to actually replacing what we're paying for the core primary care services. And get that to what you've heard of as a capitated payment or a per member per month that isn't just in addition to the core medical services, but actually paying for those core medical services. It would require in the bill a report by January 2027. Importantly, in my view, with input from primary care practitioners on the Comprehensive Primary Care Steering Committee and the Blueprint Executive Committee, how do we transition from this add-on PMPM to actually covering what's typically a billable primary care service? We think we actually want that more input. We want time to design that correctly, but it also asks for an operational plan to implement these changes no later than January 1st, 2028. We want to move the needle. We want to move towards this as quickly as possible, but we want to get it right. So again, why take this approach? Why build a fee-for-service replacement or a comprehensive payment off of the Blueprint model? The Blueprint already has with the end of the ACO, really our only multi-payer primary care program in Vermont. They do that. They have a methodology for how do we attribute patients, which payer are you attributed to? How do we get the money out to you? They have relationships with our primary care practices in the state. So we think it makes sense to build off rather than making something new. That was a concern we heard in the Senate with S197 as introduced, is the way the bill sounded like what it was asking for a whole new primary care payment program. Who would do that? How would we pay for it? How would we staff it? We actually have a primary care program in Vermont, and we build off of that. We do think some time makes sense to get it right. So that it's actually not as simple as just making a monthly payment. We have to decide, what are those core primary care services? Does that look the same for every practice? What if this practice does X-rays, dental services, lab work, but another practice doesn't? Are we paying them the same? Which things actually go in a capitated payment? Which things do we maybe want to keep fee for service? We've heard from some of our members, maybe vaccines should always stay fee for service because we actually want more of them. One thing fee for service does is it can incentivize actually doing more of something, so that things we do want to see more of and that maybe are a little more procedure based, maybe those need to stay fee for service. Or if we want to incentivize primary care to do, say, a mole removal, so they're not being sent to dermatology where it's more expensive, maybe some things we actually don't want to build into a fixed monthly payment. We want to actually give you an incentive to do more of. So I do think we couldn't tell you tomorrow, we couldn't start this new program tomorrow because we don't know exactly how to do it right that will work for primary care practices.
I was going to say, I think Leslie had a question. Did you want to wait? Okay. Thank you. I mean,
Sure.
sorry.
Yeah, no, I did look like that.
And why not? I heard some testimony this week about rate setting. Why not just go through a rate setting approach? I think you've heard testimony that there's sort of two things primary care needs. They do need more investment and a bigger proportion of the spending, but they also want to get paid differently and be paid more globally. And a rate setting methodology is really, in my mind, still a fee for service methodology. It's just saying pay more for those fee for service items. It's not saying how do we turn this into a capitated payment or program. And also a difference or distinction from some other proposals on the table is that it doesn't require creating a new sort of insurance type infrastructure or insurance type system. We're saying your existing insurer, whichever that may be, you may be on Medicare, Medicaid, commercial, you still pay your premiums to them, you still stay, covered by them. They would just be making a payment to the Blueprint that would then go to a proportion of your primary care services.
Can they up your premiums with that, or? If I pay a monthly payment or whatever, and if they start paying this fee or whatever, will they increase my premium cost, or will it come out of what I pay?
So again, this is why we need some time, I think, to develop this correctly, but the goal would be this would not be just additive, that the insurer could take the proportion of the premium dollars that are already going to primary care and then contribute it to this Blueprint program, and that would cover those primary care services. It wouldn't be sort of double. It wouldn't be like they would be charging you to do it fee for service, and they'd be paying this amount to the Blueprint. The vision would be that they're directing the payments they would be making directly to the providers to go this other
Hopefully.
funnel. Yes.
Okay.
And that's a little bit up to the insurer
Oh,
too,
yeah.
right? So let me go back to the ERISA example, the large employer plans. We can't tell them to not offer primary care services. They design their own plan benefits. However, if they are being charged a sufficient assessment to cover primary care services, why would they also continue their fee for service program? They could make that choice, but it may not make financial sense for them to do that. Again, with the whole goal, and I think insurers really do believe, at least the ones we've been speaking to, that primary care is good for their members. They want their members getting primary care services. It saves everyone in the long run money and gets better care. So then the step 3 is we're talking about the payment that the payers are making for the primary care services going to the practices. Could that cover and include patient cost sharing? So could there be a way that this model could be expanded to say patients don't have to pay out of pocket for primary care services? There are differing views of whether this is a good thing or not a good thing. I will remind folks that everybody on a state regulated plan gets 3 primary care visits with no cost sharing. But do we want to expand that? Do we want to say everybody, primary care is a good everybody should have access to and not pay out of pocket? We would argue that's a good thing, that we don't want out-of-pocket costs disincentivizing people seeking primary care. It's already in a way embedded in the Blueprint model that all patients get access to all the Blueprint programs of that practice, regardless of insurance status. They don't have copays when they see the community health team worker. So can we kind of envision that as the whole Blueprint payment includes that? You look like you have a question, but I can keep going or stop.
I don't want to go. Okay, so first of all, Eli, I got the report from Jessa, so no need for that anymore. Right before you came in, I'm like, can you find me the Act 51
Oh,
report?
it's linked. Yes, I linked to it. Yes.
It's linked to it. So what was the outcomes of that report?
It came to this body, and it is one of those reports that was delivered and is sitting.
I should say, actually, what were the recommendations of
The recommendation, so I'll go back, the recommendations were to bring all payers up to the level of Medicaid. And could we explore this concept of, is there a way to bring the existing payers who contribute, so that's really MVP and Blue Cross, up to Medicaid's level? And can we or we should look at ways to then get all commercial, including the self-insured, to contribute?
So one of the other things that we asked in the Act 51 report was, should the per member per month, or actually, we didn't ask if it should be increased. We asked, what should it be increased to?
And
the report came back with essentially commercial payers should increase up to Medicaid, but it didn't actually indicate that the per member per month should go up. So, and the reason I'm thinking about this is, on your step 1, 2, and 3, the infrastructure that we have already with the Blueprint, the relationship with the Blueprint, with providers, absolutely Blueprint. I am fully on board with Blueprint being like the pass through. That's not where I'm struggling. I'm struggling with the Blueprint and AHS designing the amounts, the methodology of how the amounts are arrived at. Because it seems to me that the very program, and Medicaid would participate in this as well, the very program that actually has a financial stake in what those payments are, perhaps the financial requirements and methodologies should be developed by a different party so that they're not influenced. Does that make sense?
it absolutely makes sense. I have a couple of ways of responding. One, this body is actually the body that appropriates the Medicaid contribution, well, the Medicaid budget. And so there is certainly an element of the whole appropriations process and the politics and policies involved with setting the Medicaid budget that comes into play in terms of Medicaid's contributions to the program. I think that there is some language proposed in 197 that requires an assessment of are those PMPMs adequate to support practices each year. I would not be opposed to strengthening that language, but I think you also and there's a whole new layer now about state directed payments. So even if your body strengthened the language in terms of requiring increased contributions, that is more challenging now. I think the reality is, even if it were another entity developing the methodology, you'd run into those same challenges of, well, is Medicaid, then you run into the reality of what can Medicaid contribute and state directed payments. I also think the other, that the blueprint has probably a better window into more of the operations and realities of primary care practices than at least currently, the Green Mountain Care Board, which doesn't regulate the budgets or see the financial information or budgets or oversee FQHC's independent practices. Maybe they have some insight into hospital-based primary care practices, but that's certainly not currently what they're looking at at any granular level. So it would take a whole new process infrastructure that's not something that body is doing.
But if we think about incorporating pieces of I can't remember which one.
680?
680. And, an investment, not just creating a methodology, but actually increasing the percentage of healthcare spending that we're putting towards, then doesn't it seem like the entity that does rate review, wouldn't they have more insight in the commercial space over what it would take to increase to certain levels of percentage?
I would ask that. Yeah, I understand your question. I would ask that of the Green Mountain Care Board and AHS. I will say we've been trying, as I think I mentioned from the sideline the other day, we have been working to get language in statute for several years about setting a primary care spend target, and have often felt caught in the middle of who should be on first, or who is willing to do that work. So I would just say we as an organization think it absolutely needs to happen, and by somebody willing to do the work. AHS and talking about 197 seems willing to do that work with us. We just want it to happen and we think it is really important. That is, and I can get to that. That is in 197 as well.
Alan, did you have a question? And then we'll let Jessica continue.
So that is the next piece I was going to get to. How does this relate to a primary care investment target? So section 2 charges the Agency of Human Services, as came out of the Senate, with establishing a target for the amount, and I'll say a little more about this, of per person per month spending that should be used for primary care services. So set what the target should be and a schedule to increase that investment over time, and says those increases should be actually directed to the PMPM that we just talked about getting established. So why take this approach? You've already heard some of this background, but there was a question about where this data came from, so I wanted to link to it. This is a National Academy of Science and Engineering study on primary care, found 35% of visits are to primary care, but only 5% of expenditures. I link also to the report you just heard from, was that just yesterday, I think, about where we are in Vermont right now, about 10.2% overall. we believe we agree with what the questions you were, or the direction you were going. We should move beyond a baseline measure to actually setting a target of where we want that spend to go and reaching that target. And there have been, I just want to be really clear what that target is. It's sort of an average target for what insurers are spending on primary care. It is not individual to you. So I think there were some questions like, does this mean I have to spend more on primary care, or my insurer will be spending more on me for primary care? This is sort of on an aggregate level. What is that insurer? How much of their spend is going to primary care services versus other services? Other states have done this and achieved them. For example, Rhode Island and Oregon have both achieved a goal of over 12%. A slight difference from previous methodologies that this bill is recommending is actually going to a per member per month target rather than a percent of spending. And I will say why, because I think you heard a little bit, are we really comparing apples to apples in the way we've measured it in the past? A percent of overall spending is very influenced by how much that ensures their total spending. So it's a percent of a pie, and if that pie is bigger, the percent may look smaller. So if Medicare is spending a lot in our state, their percent may look lower compared. So it's a little bit harder to compare plan insurer to insurer, how much is really going to primary care. So this is actually saying per person, how much do they spend? So it's a little more normalized across payers. That was a recommendation from a recent report by Maryland's Healthcare Commission on how they are going to start measuring primary care. They recommend starting to measure primary care investment in their state. So we also believe that it's important to have some sort of guardrails of where that investment goes, so that making sure it's really ending up supporting primary care, rather than if you leave it completely open-ended. Some states at least have started out that way with their targets, like it's completely up to the insurer how they accomplish that or where it goes. That's a little harder to know. Is this really ending up supporting what we want it to do? Whereas if we say this is going to this payment program we are establishing, we know it's getting in the hands of primary care to deliver primary care services. So then there's some other reports that I just want to link back to what we're saying. There's a report saying that there's a section saying that the report should give some guidance on what definition to use. You heard the healthcare advocate say, I had a little different view. He thought that was a very painful process. There were a lot of meetings, I will admit that, of how should Vermont define primary care. So rather than rehashing definitions, there's been work done both regionally and nationally on this issue of primary care spend target. Let's pick a definition so we can compare to other states or nationally what definition it is. If we are doing the AHEAD model, they already have some guidance around how to establish that. In fact, they require states to set and meet a primary care investment target.
This is just a timing question. We keep referring to if we do AHEAD. So do we know when we'll know if we are doing AHEAD? Or, because I feel a little like unstable about.
I am right there with you.
Yeah.
I do not have an answer. I don't know.
Okay. So we keep saying if, but maybe we should.
We should know. Well, I mean.
Or no, or something. I don't know.
Right, and it would be to start by 2028. So I assume those conversations would need to be going. I mean, I know there have been conversations. I don't know the latest on where they are or how optimistic they are feeling.
I just feel frustrated by the idea of we're going to do all this work dependent on maybe we're going to do AHEAD and then we don't, and then it's all been for naught.
I agree. That is why our organization is not willing to just wait to see what primary care payment looks like if we're in AHEAD or not. I think we have consciously tried to craft 197 where it could work with AHEAD, but it is not dependent on it.
Well, that would be what I'd like to understand, how it separates. What's dependent on AHEAD? What would go stand alone, I guess.
The only thing dependent on AHEAD would be would Medicare participate with us? Medicaid, the commercial, all that work, the blueprint would all still exist. Medicare, CMS has said they're willing to keep funding their contributions for their Medicare, folks. If we are in AHEAD, I don't know what happens if we're not in AHEAD. Would CMS still be willing to make a contribution for Medicare covered individuals?
Okay, well, that's helpful. At least it's just that one population.
Yeah, that's my take on it. Yeah.
Which is like all of the state of.
It's a growing percent. We really want them in. They make a very meaningful contribution to the blueprint. It would be and I think you've had this conversation around the budget. They're actually not contributing for 2026 7. Do I have my numbers right? Because because we're sort of in this year where we're not actually in a head yet.
Yeah.
So the state has sort of filled some of that, what Medicare's contribution would have been.
And does any of this have to do with transformation or nothing?
There are dollars in the RHT grant or proposal to also work on strengthening the blueprint. I think it is very well aligned, but I am not sure. But I would encourage you to ask, get more information from AHS around that. I don't yet have a lot of clarity on exactly what that blueprint investment would look like from RHTP, but that is a bucket that is earmarked in there, which is fantastic.
Okay, so it's like 3 moving parts. Well, there's this bill, there's a head, and there's, sorry.
RHTP. My view, but feel free to ask others, is they all could work together. They're not contradictory or conflicting. They could complement each other.
I'd be curious to know how that works.
And they don't rely on each other.
That would be I'd be curious to.
I don't remember if the rural health transformation grant is allowed to be used for studying things. Do you remember? Does anyone remember?
I don't recall an explicit prohibition on that. I don't think so. So I think there could be some opportunity.
It's like an AHS question.
Right.
The reason I ask is because I'm just thinking like, how do we use what we have while we have it? And I know that that's one-time money or it's like one-time money over a period of time. So we can't rely on that to keep to maintain a system. But if we could use that money to study how to restructure the system and finance it better, that would be great. And while I'm talking, I wanted to just comment too that I was listening remotely and we talked the other day about this idea, but it's exciting to hear that we might be able to use the blueprint, build on it to expand access to primary care. I mean, it sounds like it could potentially be used to provide it as more of a basic public good based on what I'm hearing, and that's exciting that's possible. I think I'm curious to learn to see the rest of what you have to say though.
I think I'm almost done. So I know it's one time. Yeah, actually, that was my only last slide. Nothing new to your committee. I will just say the bill also includes the striking the sunset on the medical student incentive scholarship program. A difference from 680 is introduced here versus 197 is 680 did include significant more investments in loan repayment and other workforce programs. You have already added money in the budget. Thank you to your committee and the House on loan repayment. We also think that's a really important component. It's not in this bill. We were being careful not to want to slow down progress by attaching a lot of appropriations to this bill. But the language strike is in the bill. So that's where I was. That is my last slide. I did want to just mention there are some other studies in the bill. You may come back to them at a later date. We are fairly neutral. Those were not sort of our proposals. I think they're fine. They're studying the clinician landscape and site neutral billing, transitioning more care to community settings, regional universal primary care. I guess I would just not caution. Our perspective is that the other components of the bill we really want to see that work happen. We want to see a lot of effort go into getting that right and moving the needle. So just when you're thinking of the number of studies and reports, our suggestion would be to really focus on the core primary care sections of the bill. But we have no problem with them in there. They're fine.
Yeah, I'm just curious, like, about the relevance of studying regional universal primary care when we may be able to, it may not be the exact vision of other bills that are out there, but we may be able to establish some kind of universal primary care through the blueprint. So I'm just wondering if, like, and you have an opinion, you said you're neutral, but if it might be better to ask the treasurer to look at regional universal health care, like how do we work with the surrounding states to not just be limited to primary care? And I don't know if that would exceed the scope of the bill too much to have him look. I mean, maybe it's just that we say, look at universal primary care and how to expand on that and work with other states to fulfill our states' I don't know, what is it, principles of healthcare reform, whatever they're called, that are in statute from Act 48. Anyway, I don't know if you have any
No,
thoughts
honestly,
about that.
I have limited insights, I would say, to these sections of the bill, because the Senate actually, unless I don't think I missed much testimony, did not really have much testimony on those studies or the intent behind them. I don't believe the treasurer's office testified, so I'm not really sure the motivation for that section. But again, I think we have had studies of both universal primary care and regional insurance models. They tend to run into implementation challenges. So whether that's what you want to look at, or if you have other ideas of what might be more productive or informative for really realistic next steps.
Leslie,
So I'm looking at this rural health transformation money thing. I'm seeing $30 million, if I got that right, going towards blueprint primary care practices, meeting access requirements. That's one of them. I'm wondering if we should get testimony on it, or I'm just wondering, I'm just seeing this puzzle and wondering how it all fits together.
we are going to hear from AHS and their thoughts around that.
Okay.
That and this bill.
Yeah.
Yeah. How it
And the
fits.
concept of that bill and other bills and how they may help one another.
Thank you.
You didn't speak to, maybe, am I conflating bills? You didn't speak to any of the sort of quality measures, we've had discussion around this.
So what the bill, sorry, not to make people dizzy here, but the bill does talk about that a bit in, when we are asking for the blueprint and primary care practitioners to design this expanded or reimagined PCMH payment to also give input on what should the agreed upon quality measures be. Because I agree, I've heard the testimony, I completely agree. And I will say there are some other, I didn't really go into it. There is the section in the bill, I think Jen pointed out, that actually gives the blueprint more flexibility. Because right now statute says you can only be a patient-centered medical home if you meet NCQA requirements. I believe the way the language, and I know Jen had to sneak out, says like, or other quality measures. So I think it actually does at least allow some more flexibility.
Ask you about, as I'm reading this bill and I'm thinking about, first of all, who would this affect? Medicaid, UHP market, essentially our regulated market.
We hope it can go beyond that.
We hope it can go to ERISA, but we're not sure. It won't go to Medicare unless we somehow incorporate it into a HED. And I'm just thinking about this from a practical standpoint of, a day in the life of a provider is you have disparate insured patients throughout your panel. And you've got different payment methodologies for different members. I'm wondering if you see, this is kind of the problem we have with Blueprint right now. Everybody gets services that are offered through the Blueprint. They're all free. They're non-billable. They're not free, but
No, they're free to the patient.
they're free to the patient. And it doesn't matter if your insurer is putting money into that Blueprint. Those patients are getting the same services, which means, and they're eligible for them, which means that some insurers are subsidizing other insurers. And how do we make this? Because I know on the ground, providers are not going to sit there and say, oh, I'm going to call in this patient's medication because they can't get here. Oh, but they have this insurance and that's fee for service, so I need to make them come in, because that's not going to happen. I'm worried that the anticipation and the sort of capitated payment participation is gonna start subsidizing
Mm.
the fee for service model, which everybody will get sort of the reimagined way a practice will work without actually paying for it. And
I don't have the answer to that today. I do know there are conversations going on between AHS and BFR and Blue Cross. So I would encourage your help to test out how we really can, or how accomplishable it is to get the ERISA plans in. I agree with, it's certainly an issue from the practice perspective of having, if you different types of payments are great, but if they only affect 10% of your patient population, it actually could end up being harder. We want everybody in. I am cautiously optimistic this is actually a way to start accomplishing that, but there are others who are more expert on ERISA law than I am.
I see Brian and Leslie. I just wanted to,
I know.
and I'm thinking back to some of the testimony that we got the other day around OneCare. I think it was the pediatricians that we had. And I was sort of chuckling a little bit to myself when one of them said that you never knew you just got money, but you didn't actually know what it was. And that sometimes the administration of different payment methodology. I mean, to me, the beauty of this is it streamlines your payments. But if you're still having to continue all these sort of administrative billing things for half your patients, but not the other half, you're not really seeing that sort of administrative saving piece to it. And Brian, and then Leslie.
So I wrote it in highlighter, so it might take a second. Okay. The first question is, are you aware of any other example of a universal fee that we're charging payers? Like, I know we have provider taxes for certain classes of providers. Are there any other like universal payer fee that every single payer that operates in the state is charged?
There is the claims tax.
Medicare pays that too?
I don't believe Medicare does, but and actually that is something that is mentioned in the Act 51 report, is could that be a mechanism of assessing all
Claims tax.
claims tax?
And that's why I asked, is because there may be an existing mechanism, or we can create a new mechanism like that, like a primary care tax or something. I don't know what we would call it, or fee. The other thing is that whether we require, I think there's a question, can we require these ERISA plans to pay a fee or not? Do we currently do that with the claims tax? Okay, so we know we can do it with a claims tax, but whether we can do it or not, if we had a fee that they paid that delivered a good that was worth it, I bet there'd be companies who were like, oh, we'll pay for that fee in Vermont, because when we pay that fee in Vermont, it allows us to lower our premiums in Vermont because it's delivering so much. Or maybe they don't lower their premiums, but it stabilizes their premiums over time if it was delivering enough of a public good. And it sounds like we haven't decided yet how it would work, but it's possible that it could be that there's some basic services that everyone gets. And then when you go above that, there's cost sharing. So there could be ways that it's structured. So I guess the question I was really asking, though, you answered, which was the claims tax thing. And so that's helpful to know that there's already a mechanism that is applicable to ERISA plans.
I believe, yes, I think so. Yeah, others,
We'll double check.
JFO and others are more the expert on the claims tax than I
Definitely on stop loss one of these days. Go ahead, Leslie.
Yeah, on these ERISA, what's the mechanism or the pathway to get that to happen? And is that in this clearly?
It is authorized in this bill because
Can you point to that for me?
because the Agency of Human Services is already authorized to assess insurers for the blueprint. That is it is the existing statute that starts on page 1 to, so it's really it's pages 1 through 2. We're on page 1, we're defining, this is all existing statute around setting up the blueprint, who a health insurer, or what a health insurer is. And you'll see, right between pages 1 to 2 is where they're expanding that to say offering or renewing a health insurance plan. And to the extent permitted under federal law, third-party administrators that administer a health
Okay, I
insurance
had a question
plan.
mark there, so that's helpful.
That's to try to get in. Okay, so you're the, Blue
That's the
Cross,
ERISA.
that's part of the ERISA plans.
Great.
Those are the ones where it's like, there may be a local insurer administering it, but it's not they're it's an employer who's self-insured. And then you will, and so then, on page, 2, the top of page 2 is where it says health insurers have to participate, basically. So health insurers shall participate as a condition of doing business in this state. And so if we are changing, and
So what
then
line is that?
that is the 12 through 14 of page 2.
I think I might be in a different version.
Oh, I'm sorry.
Because I don't have as passed.
Oh, I'm sorry. I'm looking at the as passed.
Yeah, that's.
Yeah.
Sorry,
So if it's in the section on health insurance, section 706 of existing law,
great.
where it's saying that, and there's already, so they can, so Blueprint's already doing this assessment. They're already getting payments from the payers that they are currently assessing. And then down at the, end is where they can appeal it to the Secretary of Human Services. So there's sort of an appeal mechanism.
Do you see a time where practices will start selling subscriptions? I'm thinking about, like, what's to stop an employer right now who only has a couple employees? They can't afford to provide health insurance. So they're not mandated to because they have fewer, but you could essentially pay a primary care physician to the same amount just to take care of that one employee, at least with the most basic care.
Isn't that concierge? Isn't that what that is?
Right, could you see an employer paying your direct primary care subscription fee?
Yeah, but I'm also seeing more of a hybrid model for practices where, yes, they are commercial and everything, but also at the same time, they've got like more of a direct primary care feeding into it, or it can be half concierge, half.
I think you tend to get into, it's hard to be half and half, I believe, because of existing insurance contracts. So many will say, like, if you're participating in, certain insurance contracts, they will say you can't, you can't take a fee above what we pay you. So you couldn't take a subscription fee above this, it's a little bit.
No, I'm thinking about like uninsured people.
Yeah.
I mean, I get, essentially it would be like a self-pay
Mhm.
subscription.
They could do it with health sharing.
Anyway, we should probably.
Yes, I've run well into your lunchtime. I
No,
apologize.
I think this is good. I mean, yeah.
Go ahead.
I just have just like an analogy to make that we're building up an infrastructure of primary care here. And we do that with our roads too. And we
Mhm.
require everybody to pay. I just don't know why ERISA, which I happen to be a part of,
Mhm.
would not contribute to this infrastructure that we're desperately trying to save.
Well, thank you.
Is there?
I agree with you.
Quantify? I don't know if there's a way to quantify how much care is being given to non-Blueprint patients. Can a practice do that? Or, I mean, we don't want more work for them, but at least to, as part of our reporting, understand what's being given away.
The Blueprint, yes, it's in the Blueprint annual report, how many of encounters with community health team members are with which types of plans.
Okay,
So they are tracking that because the existing insurers who pay want to know that too. Like Blue Cross wants to know, okay, we're contributing to the Blueprint, what are we getting for that? So that that is in their report.
that's great.
Thanks, Jessica.
Thank you very much. Thanks for your time and attention. I really appreciate it.